Hi, this is Elliot Fishman, and welcome to part 4 of our look at small bowel obstruction. And as we finished part 3, we talked about what causes 5% of small bowel obstructions, and that would be neoplasms. So let's take a look at neoplasms. Here's a good example of a patient with obstruction, and you can see the dilated duodenum, and then there's a transition point. This patient has obstruction at the level of the ligament of Treitz, and this is due not to a primary duodenal tumor, but to pancreatic cancer. It's a nice example of a tumor like pancreas causing bowel obstruction. We usually think about pancreatic head tumors and involvement of duodenum, but tail tumors can present with gastric outlet obstruction or bowel obstruction, or at least that's the clinical presentation due to tumor infiltration, nicely shown here. Here's an example of diffuse thickening from literally the third portion of the duodenum into jejunum. There's diffuse infiltration. There's proximal bowel dilatation. You can see very nicely here the transition point right there and there. And as you look carefully at this, it's infiltrated. That's maybe very distal duodenum, but it's more in the jejunum, very nicely shown here. And this is a carcinoma causing proximal bowel obstruction, nicely shown also on the cinematic rendering, very nicely shown there. And you can see, again, the simple findings. Bowel dilatation, we're looking at the transition point. We see that it's at the region of the ligament of Treitz, and we recognize there's a mass, and the differential would include adenocarcinoma, lymphoma possibly, doesn't look like a GIST tumor, doesn't look like a carcinoid tumor. Lymphoma can be very bulky or just infiltrating like an adenocarcinoma, though lymphoma, as in this case, often has nodes that are bulky. Here you can see a large bulky nodal mass infiltrating and encasing the mesenteric vessels. Now, I will admit lymphoma, even when it's bulky, tends not to obstruct bowel, but here there is some dilatation of the proximal jejunum, but a very, very large mass in the mesentery with encasement of both arterial and venous structures. When the mass in the mesentery is this large, it's going to be a lymphoma, typically a B-cell lymphoma, very nicely shown in this example. And again, shown well on the cinematic rendering. Now, we talk about lymphoma, and lymphoma has many patterns, from solid nodules to polypoid nodules to infiltrating tumors. And the infiltrative form is probably the one that we think of most as causing bowel obstruction. But of course, the polypoid lesion form can lead to intussusception, leading to bowel obstruction as well. Carcinoid tumors tend to have two things. One is a mass in the mesentery with desmoplastic reaction, and then possibly the mass in the small bowel proper. You often will see dilated loops of bowel. You can see here there's lots of dilated bowel, which is edematous. And then you can see there's a mass in the mesentery with calcification present, and then the small bowel mass. Now, in terms of desmoid tumors, in terms of carcinoid tumors, in terms of lymphoma, in terms of sclerosing mesenteritis, any of those entities can have calcification, but about 70% of carcinoids have calcification. But you also see the desmoplastic reaction, and then, of course, often we'll find the mass in the small bowel. Primary tumors from carcinoid not always are going to be vascular, but you can see, look how edematous the bowel is. Now, it's interesting with carcinoid, it doesn't necessarily mean the bowel is ischemic. Often the desmoplastic reaction will cause this thickening and edema, and I surely would worry about ischemia, but usually these patients are followed, treated with chemotherapy, and typically do not cause perforation or obstruction. Here's a few more of those images with volume rendering and with cinematic rendering. Very, very nice example. Now, here's a mass in the mesentery with calcification. Now, if you had lymphoma and lymphoma was treated with radiation perhaps, I could say this could be nodes that are calcified. But here, there's no history of that, and there's a mass in the mesentery. There's thickening and encasement of multiple branches of the small bowel. There's a desmoplastic reaction. The differential is between carcinoid and sclerosing mesenteritis. If you find a mass in the small bowel as the carcinoid primary, then it's easy. It can be somewhat tricky. The carcinoid, and this was a carcinoid, is more likely to encase the SMA and more likely to encase the SMV with multiple small collaterals, but it can often be a difficult diagnosis. Sometimes biopsy is helpful, but biopsy will often have the pathologist say, well, I don't see a carcinoid tumor. It doesn't mean there's none present. Some people have tried dotatate scans looking for carcinoids, and if the dotatate is negative, then it's more likely that it's going to be sclerosing mesenteritis. Here's a patient with abdominal distension. This is a classic example of Pseudomyxoma peritonei, carcinomatosis, really impressive on the omentum and into the mesentery. There is bowel loops that are mildly dilated. It's interesting when you have Pseudomyxoma peritonei, you may see bowel obstruction, you may not. Things that give pseudomyxoma, mucinous tumors of the cecum, gastric adenocarcinoma, ovarian cancer, biliary duct tumors, pancreatic tumors occasionally, and mucinous tumors in this case was from the appendix. So one of the things when you're looking at abdominal distension and you're looking for bowel obstruction that can sometimes, at least clinically, confuse you is pseudomyxoma because there's such mass-like and protuberance of the abdomen. When you look at the bowel in this case, you see there's minimal at best dilatation, but it's the mass effect that's causing the problems. And the whole idea about appendiceal carcinoma can be a tough diagnosis. If you see a mass in the appendix and it's large and it enhances and it has calcification, you would worry that the patient just doesn't have appendicitis, but perhaps has a mucocele. It's often a very difficult diagnosis, and it's typically made at pathology. Here's another patient with looks like Pseudomyxoma peritonei, impressive nodularity in the omentum and mesentery. The small bowel is really not very dilated, but what are we dealing with? And normally I would say to you, this is the same as the last case, Pseudomyxoma peritonei. Think of stomach, look at the ovary, look at the colon. This was tuberculous peritonitis, and it's unusual, and I was once showed a quiz case of a patient from Ethiopia. So the answer is if you have a younger patient, particularly a patient with foreign travel, particularly to Africa, you got to think about TB peritonitis. It's a great diagnosis, but you could see it's a great mimicker as well. So it can indeed be very challenging. Now, one of the things in terms of tumors, and this is true with any tumor, both benign and malignant, it could be true with lymphoma, adenocarcinoma, it could be true with a lipoma. You can get intussusception. Now, intussusceptions will cause small bowel obstruction, and you usually can find the intussuscepting zone. You can see one intussusception or you can see multiple. When you talk about tumors and you have multiple intussusceptions, I'm typically thinking about lymphoma. Otherwise, we think about things like melanoma, lung cancer, breast cancer, and renal cell carcinoma. As I mentioned, intussusceptions, we have malignant causes. You can also see functional causes, celiac or Crohn's disease. You can see benign causes, Meckel's diverticulum, cystic fibrosis. You can see it with benign tumors, Peutz-Jeghers polyps, inflammatory polyps, and lipoma are all possibilities. So intussusception is one of the causes of small bowel obstruction. Again, typically what you're going to be doing is following the images, following the dilatation to the transition point, and the transition point is at the intussusception. Examples, dilated bowel loop, then we follow it down, and here's the intussusception. This was a patient with Peutz-Jeghers syndrome with a polyp which caused the intussusception. There's the polyp. You can see how it draws in the mesenteric fat right into the lesion, kind of a classic appearance axially and coronal for an intussusception. And again, here's a few more views of that. You can see some of the vessels being dragged in with the intussusception Again, nicely showing you that on the cinematic rendering as well. And here it is again. A really nice classic example of an intussusception. Another patient, abdominal pain and distension, bowel obstruction. And here you can see the transition point. What's going on right here? There's a mass. That's a classic look for an intussusception. You can see the dilated bowel. There's the intussusception. You even worry about a second site of intussusceptions. As I mentioned, multiple intussusceptions. You got to think about tumor. You got to think about lymphoma. But here, just a really nice example. There's the intussusception. What could it be? It could be a range of possibilities. I don't see any adenopathy. I don't see any other tumors. The liver looks okay. I don't see the spleen. But this was an intussusception. You could see it very nicely as well on the multiple cinematic rendered images. And this was a patient who had lung cancer. And as we said, melanoma, lung cancer, breast cancer, and many other cancers are all things that can give you intussusception and lead to bowel obstruction. So again, a very nice example of bowel obstruction due to metastatic disease to the small bowel. Here's a patient with adenocarcinoma of the colon. There's bowel obstruction present. You can see the dilated bowel. We'll track it downward looking for the site of intussusception. And you can see right over here, there's a transition point. There's a mass which is extending into the bowel. A really nice example of showing you on the coronal and on the 3D volume rendered images, which you see here, the transition point. The bowel is dilated to that point, and then the bowel is narrowed, and there's areas of thickening and enhancement. You could see it very nicely here on the cinematic rendering as well, and here as well. And that ended up being a carcinoma. Again, it could have been metastasis. It was a primary adenocarcinoma of the patient's small bowel. I showed you a similar case before about carcinoid tumor. Again, I just want to make the point about carcinoids looking for the mesenteric mass. So when you're thinking about bowel obstruction and you're thinking about carcinoid, look for masses in the bowel that may be not the cause of obstruction. The desmoplastic reaction is often what's going to cause the obstruction, but there may be a mass more distally in the small bowel. And so carcinoids are a little bit different. It's that combination of tumor and the patient's desmoplastic reaction. We are better at finding the tumors now as we do dual phase imaging and thin section CT, but even with the best protocol, it can be difficult to see the primary carcinoid tumor. Sometimes nuke studies like dotatate studies can be better at finding the primary tumor. But again, put all the information together and think about the transition point, and in this case, the patient's carcinoid tumor. In terms of cinematic rendering, I've showed you, or I've snuck in a few cases with cinematic rendering. I think it can be very valuable in looking at transition. It really is nice at showing you the dilated bowel, the bowel wall enhancement, the vasculature, and anything in the mesentery. Okay, so a really nice example. And you can see that some of the thickening of bowel, and you'd begin to worry that this bowel is becoming ischemic. As I mentioned, bowel looks worse with carcinoid tumors than it actually is because a lot of the patients are simply followed and the bowel pattern never changes. Patients will typically be getting chemotherapy and not getting surgery, debulking procedures. Now another patient, right lower quadrant pain and bowel obstruction, you can see the dilated bowel, you see a mass. Could this be in the terminal ileum? Yes. Could this be lymphoma? Yes. But could it be in the cecum? And I showed you some cases before, like a cecal volvulus, where the primary process is in the cecum. And here you can see the primary mass is a bulky tumor, which is in the cecum, but also involves the terminal ileum, and that's where the site of obstruction is. So when you see something that involves cecum and terminal ileum, yes, you could say colon cancer, but when it's very bulky, think about lymphoma. That's a good possibility. And when you scanned upward, you saw lots of nodes in the peripancreatic region, in the paraortic region. You also saw splenic lesions. When you have a mass in the cecum, you have nodes and a splenic lesion, I'm going to think about lymphoma. And this was B-cell lymphoma presenting with bowel obstruction. But again, the tumor wasn't in the bowel itself, though it did involve the distal bowel. It was really the cecal component that was the big problem. Now, when we look at surgical emergencies in the oncology patient, we just had a recent presentation about that. And one of the things, of course, you look at is tumor growing, causing obstruction, but you also look at other complications, including obstruction due to adhesions or any post-surgical complications. So that's an important thing to really think about. Bowel obstruction in oncology patients can happen as a result of the tumor, as a sequela of post-operative adhesions, a mesenteric defect, or post-radiation changes. Patients with bowel obstruction present with abdominal pain, nausea and vomiting, and distension. And 5 to 15% of intestinal obstructions have been associated with cancer. So again, very, very important. And when you talk about obstruction in patients with known cancer, small bowel obstruction happens more frequently than large bowel obstruction. And this article by Puyan is a good article. We also published an article, literally it's in press, looking at this process in detail. Now, one of the other things, of course, we talk about with small bowel obstruction, again, looking at the range of processes from extrinsic, intrinsic, intraluminal, and we just looked at a lot of cases of primary tumor. But another thing to look at very carefully are the range of processes, what I would call inflammatory and infectious. And the classic one would be Crohn's disease, right? We talk about Crohn's causing bowel obstruction, causing fistulae, causing abscesses, the increased incidence potentially of cancer in long-standing Crohn's disease patients. But let's do this. Let's take a break right here and come back, and we'll pick up with Crohn's disease in a few minutes. Thanks very much. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.